we evolved from the literature that we have known over in with regards to neurodevelopmental outcomes in children with congenital heart disease.
So it is on speaker, yes, the speaker sort of view. Do you want that?
Sure. You know what? Let me just escape out. I'm just trying to figure out how to do this on Zoom. It's a little bit different.
I know.
So let me just, would this be better?
Yeah.
What? We may have to go through this version.
Okay. You know what? You can put it back. It's up to you. You can put it back the way it was, maybe.
It is not.
There you go.
There I am. Okay.
Yeah.
Excellent. I'm learning about how to, it's a different technology here. All right, so perhaps we'll just get started. So we have nothing to disclose in terms of conflict of interest. So the objectives for today's discussion is really to describe the prevalence of developmental disorders in children with CHD, review the guidelines for developmental screening and how we have integrated into our follow-up program here at Sick Kids. Briefly discuss what is neurodevelopment and what is the role of the cardiac follow-up program, and then really talk about sort of overarching sort of the organization structure and some of the assessment tools that we use within our follow-up program. So CHD prevalence accounts for about a third of all major congenital anomalies, and with a birth prevalence of about 6.9 per thousand live births here in North America, there is significant regional geographical differences, with Asia being one of the highest prevalence, followed by Europe and then North America. Approximately 2.4 per thousand live births will require catheter-based or surgical intervention in the first year of life. And due to improvements in surgical technique, critical care, early diagnosis, approximately 85% of children will survive into adulthood. However, this is modified based on cardiac complexity, race, and sex. When we think about neurodevelopmental outcomes, we really need to recognize that it is multifactorial causation in our understanding of why some children do well and other children continue to have developmental deficits that span across their entire life. It really takes into the cardiac anatomy and physiology, complexity of the underlying cardiac disease and requirements for surgical repair, changes in brain development, and acquired brain injury that occurs both preoperative, intraoperative, and postoperatively, and patient-specific factors such as prematurity, social determinants of outcomes, and underlying genetic syndromes. During the third trimester of fetal life, there is a significant period of brain maturation that occurs and increases in neuronal connectivity. To support this, approximately a quarter of the combined ventricular output from the heart is directed to the brain. In babies with complex CHD, cerebral oxygenation is impaired, and this leads to delays in cortical development that occurs across all regions of the brain, such that MRI imaging shows decreases in volumetric growth, both in total and regional levels, that affect the cortex, gray matter, white matter, and cerebellar volumes. Furthermore, cortical folding and white matter maturation is also impaired. In children with complex CHD, approximately 40% of children will have acquired brain injury preoperatively, and they are often found as focal white matter injury and small focal strokes. There are also additional risk factors from intraoperative methods of cardiopulmonary bypass and deep hypothermic circulatory arrest that has come through in many of the large trials coming out of Boston with the TDA population. About 10% of children with strokes are clinically silent, and these are only found on MRI imaging. So in 2012, a group of experts came together to really develop neurodevelopmental, to provide guidelines in terms of the evaluation and management of children with CHD. And this really reflects the knowledge of the time that when we look at the complexity of congenital heart disease, this is directly correlated with the prevalence of neurodevelopmental impairment. On the right-hand side, you will also see there an exception in children who have underlying syndromic diagnosis for which they are at high risk of severe impairment. However, with the rest of the group from mild to severe CHD, even the children with who are palliated, the main many of the children do not have severe impairment. And what we're really looking at, the mild to moderate group of children with impairment, such that it is high prevalence and low severity. As we look into sort of what is that cardiac phenotype of developmental disorders, this is really much more, it becomes much more obvious that despite the differences in cardiac physiology, the impairments in executive function becomes what we call a cardiac, almost a signature of development within this population. There are mild cognitive impairments, impairments in social interaction and social cognition, understanding of facial expressions, understanding of the nuances of differences in children learning and theory of mind. There are impairments in core communication skills that is even obvious in early infancy in terms of expressive language delay. And furthermore, these children are at high risk of ADHD. In the TDA population, what has really been most striking is that these executive function deficits occur across the lifespan from childhood into adulthood, with increasing prevalence of issues of mental health issues of anxiety and depression, such that when we think about intervention and improving outcomes in this population, we really need to take a targeted approach across the lifespan. As part of the AHA developmental guidelines, they identified children who were at high risk for developmental disorders. And these were children who had required cardiac surgery as a neonate or an infant, children with cyanotic heart delusions not requiring surgery, such as the tetralogy of Fallot with pulmonary atresia and MAPGAS, and children with co-CHD, but also with comorbidities, such as prematurity, less than 37 weeks gestation. Some studies have noted less than 1,500 grams. Any child with early developmental delay, genetic syndrome abnormalities, the need for ECMO, heart transplantation, CPR, children with prolonged hospitalization greater than 2 weeks, perioperative seizures, significant abnormal neuroimaging or microcephaly. What has not been noted but is recognized is that children with postnatal diagnosis of CHD also conveys a risk factor for poor outcomes. So they have put together, through the American Heart Association, a comprehensive guidelines with regards to developmental surveillance and diagnosis. And it is, I would highly encourage those who have not had a chance to read the article, through which outlines sort of the evidence to date, our understanding of the trajectory of this population of children, and really how they've been very clear about sort of what is a need, depending on whether or not the child is noted to be high risk or low risk. That in high-risk children, all children should receive a formal developmental medical evaluation, really consideration for early intervention services, and followed by periodic reevaluation. And even in children who are noted to be at low risk, those children who perhaps may have just an ASD or VSD, that a developmental surveillance should continue to occur in this population. So I'm just going to switch this over to Kim.
So as part of our talk, I just wanted to talk a little bit about neurodevelopment and really what it is. So neurodevelopment is really the development of the nervous system. So the relationship between the brain and development, and those that innate motivation that infants have, patterns of behavior and stimulation from their environment that they obtain to really get the skills that they need to become upright. And being upright, then we become independent. And we know that any deviation in this process can lead to delays or disability. And so we've listed a few here, just having a cardiac issue as a baby, brain injuries, genetic causes, and prolonged hospitalizations can all contribute to delays in development. And we know that many of the cardiac children can actually have a multitude of these issues just by the nature of the fact that they have to be in the hospital for a long time, and they can have comorbidities and often, or sometimes, associated brain injury. We also know that the socio-determinants of health, whether they can be either protective or a risk factor for many children. And this includes socioeconomic status, access families have to resources, parental engagement, parental mental health, and maternal education. So just a little bit about Canada and Ontario for those of you who are not Canadian attendees. Many of our patients come from all over Ontario, and actually 50% come outside of the Greater Toronto Area where Sick Kids is located, and even sometimes out of province, as Sick Kids is really the major cardiac center in Canada. And so our follow-up program, so like Dr. Lee had been discussing, we follow the most patients, the highest risk patients for delays. And those are the single ventricle patients, those who've had cardiopulmonary bypass surgery within the first 6 weeks of life, and those born under 35 weeks gestation with a complex cardiac disorder. For those of you who are also not from Canada, the program is funded through the global operating budget of the hospital. And the physicians are paid through OHIP, which is a fee-for-service program that all Canadian citizens have access to. And we were really able to leverage our follow-up program by using pre-existing infrastructure. So programs that were already in place at the hospital, the neonatal neurodevelopmental follow-up clinic, the neonatal neurology consult service, and then the neuropsychology team that we have available at this hospital. And our program is really the first Canadian program that has an integrated approach across multiple disciplines and combines imaging, so pre and post-operative imaging for these patients, a neurology consult, and then the neurodevelopmental follow-up through our clinic until age 3 years, and then the neuropsychology clinic after that. So I'm just going to spend a little bit of time talking about our program. We have a really nice link between the inpatient and outpatient services where Vanna, who's our cardiac neurodevelopmental NP, is sort of a program liaison. So she will make referrals from the inpatient to our clinic for these children to be followed. And because not all neonatal follow-ups clinics include cardiac patients, we really have this expertise cohorted here at Sick Kids. And we offer that in-depth consultation and assessment by a multidisciplinary team as outlined by the AHA guidelines. So we typically see children in the cardiac portion of the neurodevelopmental clinic at 8 months of age. And this is really because they usually have had multiple interventions or hospitalizations during those first 8 months. So we really want them to have a little bit of a period of being well before we do see them in clinic. So we'll see them at 8 months, 12 months, 18, and then 36 months. And we really correct until they're 2 years of age. In the first year of life, we're really looking at those fine motor skills, those gross motor skills, emerging language development, their growth, feeding, and some of that parent-child interaction. And then at 18 and 36 months, we're really looking at how children are thinking, learning, problem solving, some behavioral and psychosocial screening, and all of these things will be very helpful when school starts. Our program does offer support of gross motor skills, fine motor skills, language development, behavior and attention skills through parent coaching. But we do not provide therapy, and we make referrals for early intervention if there's issues with these things identified in our clinic. And there's many free programs in Ontario. So we have our local health integration network, which is essentially home care programs for occupational therapy or physiotherapy. Infant development programs, children's treatment centers, public health nursing through Healthy Babies, Healthy Children, even free library programs, and something called Early On programs, which provide a place for parental education and opportunities for children to socialize, as well as parents to socialize. Something else that we have recently started in our clinic is opening the conversation on parental mental health. So we recognize that the majority of what is seen by a lot of these families in the newborn period can be unexpected and actually quite traumatic. So we do have a voluntary high-level screener that is used to help with recognizing parents that might be experiencing signs of needing further assessment by their family physician. We are a pediatric institution, so we cannot treat adults. However, we know that parental mental health is really a very important factor in child development and therefore an important part of our assessment. We've already mentioned the importance of the anticipatory guidance and education, and that's really a large part of our clinic visits. And then we know from the research, as Dr. Lee had already discussed, where these children are going to struggle. And we want to be able to give parents ways of helping to intervene at home and what they can do to help out with their child at home. We know that discussing development is really stressful for parents, and this can be even more apparent when their child has been so unwell and gone through something like a cardiac procedure. And parents are usually just so happy that they're healthier than they were initially. But the concern is that once you're behind, it can be more and more difficult to catch up as a child gets older. And the research has shown us that where children are when they enter school are sort of predictive of what they're going to be like throughout school and then on into their lives. We really do try to frame our guidance in a strength-based, positive parenting manner. And we really want to point out what parents are doing well and how they can optimize and enhance existing behaviors that the family or the child already has. So just a few examples of some of the recommendations or parent coaching that we do give. So we help parents to recognize that their interaction with their baby is so important and to try to treat them like any other baby as best they can. For example, once they're allowed to start tummy time after surgery, ensuring that they do have that tummy time to really work on that core strength and then their gross motor skills, talking to them, singing to them, reading with them when they're maybe too unwell to do some of the gross motor activities, taking the time to play with them and really making that sort of a special play time together, and taking them out for socialization once that's something that is maybe allowed within the COVID-19 restrictions. We also talk about well baby care. Sleep is a really important one. So teaching children how to have those extended periods of sleep, being able to self-soothe if they wake up at night. This is really a gift for children to be able to learn this. Also the importance of building a routine. So knowing what comes next helps with transitions, the small ones such as it's time for bed, and then those bigger ones like it's time to go to school. We do talk about screen time because there's already guidelines published by the Canadian and American Pediatric Associations that there's already some evidence that screen use is linked to delays in language development, and that's something we don't want to add on to a population where perhaps some of those issues might already be a risk. The structure of community programming, like we were talking about, although it's something that a lot of children aren't able to engage in right now, playing with those same age peers really helps teach the child about the world, language development, rules, and prepares them for school, which then again prepares them for life, because life is really about navigating that really big playground. Executive functioning, teaching children self-regulation, managing emotions, focus and attention, impulse and control, just like Dr. Lee was talking about that, some of these issues that children might have. This is really all going to help with school preparation. So the earlier we can start to address some of these issues, hopefully the better success that they're going to have at school age. In the end, it's really about encouraging independence for your child. As difficult as it is for parents, for us to let go of our kids and let them do things on their own, they have to learn that they have these abilities and that they can take care of themselves. We have put together on our Build Kids Health website, which is the Hospital for Sick Children parental resource. We do have sort of a hub of materials that we put together for parents to be able to access as well, so they can have constant access as issues come up with all of the things that we do discuss in clinic. And these are the few of the these are the assessment tools that we have been using in our clinic. Once again, in 8 months, we do that high-level screener for post-traumatic stress, the modified perinatal parental questionnaire. We do the AIMS for gross motor skills, the posture and fine motor assessment of infants for fine motor skills, and the communication and symbolic behaviors developmental profile of infant toddler checklist for communication. At the 18 and 36 month visits, we're also doing the Bailey 3, ASQ, and MCHAT. And we've also, once again, started using the WIPC to be more consistent and help with standardizing outcomes as part of the cardiac neurodevelopmental outcomes collaborative database. As part of our clinic as well, we participate in research studies and we contribute to the databases of information that help to inform care that is then provided to the care that's provided in the ICUs, and then the discussions that we have with parents. One of the most recent papers that have come out from our institution was really talking about the association between agent arterial switch operation and the impact that it has on a child's development, and the outcomes, and this was from our institution, and it really found that the timing of surgery does impact a child's outcome. And so earlier surgery does improve their outcomes. So just to conclude our talk, so we know that children with congenital heart disease are at risk of developmental disorders, and the ongoing surveillance throughout childhood is really important. And if through the surveillance risks are found, then they should receive formal developmental assessment to follow up on this. And if you do have families that would qualify for this program, we would encourage them to attend the program, as we do know we're able to make a big impact on their outcomes.
Thank you. Any questions for Dr. Lee or Kim?
Yes, ma'am. Hello.
Hello.
Hello. Is it audible, ma'am?
Yeah, we can hear you.
Yes, ma'am. Ma'am, I have a question. If we have a cardiac disease like TGA, if the baby is undergoing surgery means, so we have to get a neurologist opinion. Is it right?
Sorry, can you repeat your question, please?
If the baby is undergoing surgery for example, TGA, so the baby has to get a neurologist opinion before going surgery. Is it right?
So I think that so what we have done is that we try to do preoperative and postoperative imaging if the baby is stable prior to the arterial switch procedure. I think that it's generally our neurology colleagues are involved afterwards, after the imaging has been done, or if there are any clinical concerns about seizures or abnormal neurological status. So I think back to your question is that we would not routinely do a neurology consult preoperatively because it would not change the decision to move forward with surgery. Does that make sense?
Yes, ma'am. Yes, ma'am. Thank you. One more question, ma'am. Hello.
Yes.
Ma'am, if the baby is post-operatively, if baby have on observation, the baby will be in ICU. So, what monitors we have to do, especially for neurological assessment, ma'am?
So it's a little bit different. So in the cardiac critical care unit, I work in the NICU, so not necessarily the cardiac critical care unit, but we do. I think it really is based on clinical observation. If you have concerns from a neurological perspective, remembering that there are a proportion of children who have small focal white matter strokes that are clinically silent and only found when we do the imaging for these children post-operative. So I think that from a neuroimaging perspective, it really should be focused on clinical concerns. And then from there, you would be looking at what you have access to, depending on what the concern is. So some units have, whether if you're concerned about seizures, then obviously a neurology consult and a consideration for a continuous EEG would be helpful. If you're concerned about about encephalopathy, then maybe think about a CFM or amplitude EEG as a way of monitoring. But I think a lot of this is really based on clinical practice.
Okay, ma'am. Thank you.
Any other questions? Okay, thank you, Kim and Dr. Lee, for talking to us about neurodevelopment, the risks of normal neurodevelopment, and then the importance of having a proper developmental surveillance program and instituting appropriate interventions, and also having a really good neonatal neurodevelopmental follow-up clinic to watch these children over years. Thank you so much.
Okay, thank you.
So everyone, our next speaker is at 11 o'clock. It's Dr. Anne-Marie Gagarian, and she's going to be talking to us about ischemic brain injury and the cardiac disease. We'll see you at 11.